think are difficult, want extra help on, always my sessions are interactive. I will make you all talk. Sorry, I'm old school like that. But remember that one of the best ways to learn is, or what's the worst way to learn? Give me 2 examples of the worst ways to learn. What I mean by learn is putting information into your long-term memory, yeah? So reading a book, attending a lecture, okay? Best ways to learn? Doing, good, kinesthetically. And the other one is chatting, talking, discussion, small group stuff, okay? So that's why gossip sticks, yeah? So that's why I make you all work hard with me. Is that right? Yeah, so if you're all prepared to do that, we'll get through quite a lot of stuff in the next 6 months or 4 months, however long you're here. So we're going to talk about newborns and feeding. Some of you might, Rosie, have you had this before? No, that's good. So I have done this. I do this one regularly because I think it's hard when you're new to peds, all right? So stop me whenever you want.
Not just when you're new to peds. some of us actually never had this as part of our training.
So I'm going to have a little chat about what's sort of normal in the first 5 days, a bit about breastfeeding because it's absolutely important that you know your stats on that, I think, okay? Crucial, because there's a huge global initiative from UNICEF about breastfeeding, but there's a massive one in particular for the UK, we'll come into why in a minute. And then I'll have a little chat about some functional disorders in the newborn, in the early age, okay? All right with that? So, and I'll put big ask because I'm trying to do quite a lot in half an hour. Ooh. Right, so tell me a little bit about, I'm just putting that up there, but I want you guys to focus on this. What is the life cycle of a newborn? Life cycle of a newborn, just born, this is the age that we all panic about, let's say 0 to 5 days. What do you expect on day 1? You will get babies who come in with normal stuff within the first 24 hours of life because nobody knows or not advised mum and dad about normal stuff on day 1, okay? And we're going to talk about normal baby, term baby, okay? Normal vaginal delivery, all right? No medical issues with mum or dad. Okay, what do you expect them to do in the first 24 hours? Sleep, yeah, good. How much do they sleep? How much should a newborn sleep?
20 hours.
Okay, we've got 20, anybody else? So none of you know. Really important, right? So the parent comes to you and says they're not sleeping very well, you haven't got a baseline. You guys need to get your baselines. Is that all right? So spend this time doing this attachment, getting baselines. Because what we're doing a lot more of in peds is normality, okay? It's talking about normal stuff and promoting normal health, okay? Is that all right? And you can only do that if you know your baselines. That's what you spend time doing in this attachment, all right? So sleep, Rosie, newborn?
About 18.
Yeah, I'd give you 18. So the National Sleep Council, there's a few places, they talk about 9 hours at night and 8 hours of naps, so newborns, yeah, good. All right, so we're going to stick with that, although there's a massive gradation that happens, which I haven't got time to go into. Please look it up, okay? And I've got some references if anyone wants to look. So 18 hours. So what about newborns in 24 hours who've had a normal vaginal delivery? Is that the same on day 1? Does anyone know about that? More. Good. Why?
You say you've not had a normal vaginal?
No, I'm talking about term baby, normal vaginal delivery. In the first 24 hours, why might they sleep a bit more than 18 hours? Because they've had a massive physical trauma, the adrenaline that's in their blood. So studies have been done on adrenaline levels in newborns. It's the highest it will ever be, ever. Okay, whether you jump out of an aeroplane, parachute, blah, 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 have sex, okay? All those things, there's nothing that makes your adrenaline that high. Probably as an analgesic for the trauma. It's a traumatic experience. Today, mum and baby usually sleep a lot in that first 24 hours. It's not necessarily abnormal. But you will get babies coming in with this problem. Most of the time, the midwives are able to reassure, but you need to just make sure you've done a good neurological examination for that, okay? But it might be more than 20 hours, okay? But I'd say 20 hours would be tops, okay? And if you've got a baby sleeping more than that, you need to be worried about pathology, all right? Good, okay, and then thereafter coming into the 18-hour zone, all right? So I'm going to put that as the first 20 hours, so 0 to 1, 1 to 2, and 3, 4, 5. What are the other things about volumes of feeding? Does anyone know about, let's talk about breastfeeding. What happens with the volume of milk the mum's producing? What's the first milk they produce?
Colostrum.
Good, and what's the volume?
Couple of mils. More volume,
Yeah, good, sorry, I will put that as 1. Yeah, when you say small, what are you talking about?
A few mils.
Yeah, good. first day, 7 mils. Okay, so we give we just talk about. Second day, 14 mils, and thereafter milk comes in. What do I mean by milk coming in? I'm just conscious of time. I'm going to move you on a bit because I always want to get through all the other things. What are we talking about? Milk coming in.
So it's changing from colostrum
Yeah.
to milk.
Okay, good. And what factors influence that? Because that is something you guys need to get really good at asking about, okay? When do you, is anyone looking, a lot of you looking at me blank faces, is that really confusing? Does anyone, no, okay, so we all know that you do small volume, highly concentrated, fats, antibodies, blah, blah, blah. You can go through that, that's a lecture on its own. I'm just trying to give you some basic points and practicalities to go home with, okay? Colostrum to milk is a massive thing, is volume change, okay? So what, so milk, that's the main thing, but there's volume and constitution, you know what I mean, change, okay? There's two things that change. So when do you expect that to happen? Yeah, good, 3 to 5 days, okay? And what happens to mum that might make you, if you want to know, you're going to get, I'll tell you this is relevant because you're going to get feeding failures, okay, that come into A&E, and you're going to try and work out what's the problem, all right? And the way to think of it is mum, baby, and breastfeeding in the middle. And there's a dyad there, yeah? I'm sorry about my pen's a bit rubbish. There's a dyad there, isn't there? There's a relationship. Everybody focuses on breastfeeding. Everyone thinks it's a breastfeeding issue. But why am I getting you? What things do you think I'm talking about when I say mum and baby separately? What problems could be with mum? So, but why? You're right, you're good. So the milk volume is down. Why? So you're answering lots of questions, brilliant, but can I ask everybody else to take part?
Her nutritional status?
Good, okay, so mum's nutrition might be anorexic, she might be, yeah, okay. So her nutrition status, but that's not a common one. Common things,
Blood loss.
good, so trauma, yeah, blood loss, section, pain, okay? All of those things. What's the other one? Really important for breast milk production. I'm looking at Rosie because she's due. But, breast milk production, what do you need to be able to do? What hormone is secreted? Yeah, prolactin, okay? So sleep deprivation, massive bit, okay, especially first time mums. So you want to talk about all those things. Anything else? So I'm gonna speed up a bit. Psychological things, so how's mum coping, all of that. That sort of ties in with all of that. And the other one is drugs, big things, drugs. What drugs inhibit lactogenesis or can make a difference to lactogenesis? There's one I want you to remember, but you can go around and lift the list up. Very important, lots of pregnant people go on it because of something that's a pregnancy-induced problem.
Antidepressants?
No? Yeah, good, labetalol, okay? So labetalol is very much known to cause inhibition of lactogenesis, okay? So there's a massive, you need to know your stuff. Don't just assume it's a problem with mum latching and all this breastfeeding technique thing, okay? You need to ask those questions. Then what about baby? What stuff goes on with baby, which might make this delayed as well? So if mum and baby have issues, the milk won't come in because you need baby to latch, don't you? You need baby to latch, stimulate, then this will come in, as you say, 3 to 5 days. But if there's a delay in any of these things, delay in milk coming in, sorry, there could be a problem with the diet, okay? So what problems with baby can cause a problem with weight failure because the milk hasn't come in?
Prematurity.
Good. Yeah.
Tongue tie, although that's controversial.
Okay, so a physical anomaly. What physical anomaly in particular am I really worried about? Good, cleft palate. How do you look for cleft palate? Rosie, how do you look for cleft palate?
Got to see the way to the uterus.
Good, and so what do you need? Tongue stick and a torch, okay? That's a guideline from 2014, massive issues with people not feeling, putting their finger in, that doesn't work, okay? You'll miss soft palate defects, all right? Palate, good. Palate, mouth, good, all right? Anything else from the physical anomaly stuff? So what about tone? Okay, floppy babies, yeah, muscular tone. So that's a huge thing, isn't it? And that goes with illness as well as Down syndrome. All right, so there's thinking about tone. And then illness, okay? So again, that's related to tone though, isn't it? So meningitis. So yes, of course, you've got to make sure, so you've got to think about that as well. I mean, there's a few more, but I'm just trying to keep it so you've got some take-home things, all right? So milk comes in 3 to 5 days. How are you going to know? So you've got a baby in A&E, day 5. What are your parameters for feeding concerns? They've been sent to you because of weight loss. Sorry, I'm so sorry about pens. What's the weight loss we worry about? What number, do you know? When is it? It's referred by midwife, weight loss. What's the number? Does anyone know the number? I know Rosie knows. Yeah, good, 10%. Is 10% pathological then?
It just raises our concern.
Good, okay. And remember, why is it 10%, not 11? Has someone done a research study? 12%? Is it? No. Nobody's done a research study on this, okay? Why is it 10% then? Because it's easy to remember. There's lots of things in medicine are 10s and 3s, okay? So just be mindful of that, because I don't want you to get focused on that. It's just, like you say, a reference point. That's really important. So what are the questions? So Rosie, I do want you to be asking, involved in this one, just because I'm trying to get you guys to think laterally a bit. What are the questions? You've got this baby, 10% weight loss, with this story, not prem, okay? And examines normally, all right? This baby looks a bit hungry, examines normally. What are the features you're going to know about whether you're going to send this baby home or not? Or any things in the history or examination or bloods?
They're not the jaundice.
Okay, excellent. Jaundice, yeah, because that might need active treatment, yeah? Jaundice, another talk altogether. Good, so you might want to check their SBR. Okay, good. Anything else?
They've been vomiting up their milk.
Good, okay. Is there any other symptoms? So, is there vomiting? Is there temperature? You're right, so that's a really crucial thing, isn't it? Temperature, vomiting. What is the other thing I might want to know?
Deciding what nappies.
Okay, so passing urine. And thinking about sleep?
Are they waking up to feed?
Good question, very good question. Waking up to feed. So I think that's a crucial question. And sleep. So remember, baby's pattern, I'm going to just take us through this quickly. What does a newborn or a new baby do? They sleep, wake, yeah, feed, might get changed, might have a bit of activity, and then they go back to sleep. And they just revert, they just keep going round and round, don't they? Okay, so if they're not waking for feeds, if they're not having this pattern, that's another worry, okay? So you need to look at their pattern, has that changed? So besides these things that you talked about, which are physical stuff, very good, yeah. Vomiting, temperature. Okay, so good, okay, so let's say all of that's okay. It's all fine, that's all fine. Passing urine, at least 4 or 5 wet nappies. Anything else you want to know? Because you want to see if you can send this one home. And the SBR's okay, is there anything else you want to below the line?
That you're going to recheck their logs.
Okay, so you want all logs, that's good, yeah. Okay, I'll give you another one, sodiums, okay? You expect them to be a bit high, but if they're more than 150, you're probably going to end up admitting, right? But remember, again, there's no research study that's, I've looked into this, there's no research study that's really good at saying, oh, if it's more than 151, it's a worry. No, it's not. So we just tend to use that. So we accept 148s and 147s, which are a bit higher. And one important question about poos. Okay, what about colour? Good. What's a normal poo? Garen, I'm pointing, sorry.
Brown.
What's the first poo?
Meconium.
Good. What colour's that?
Green.
Why? What's green? What's green in the body?
Bile.
Good. So it's bile salts. Excellent. Mucus, a little bit of cells. Yeah, a bit thick, sticky. Who else passes meconium besides newborns? Could you pass meconium? One of you guys? Yeah. Yes, you could if you were TPN dependent and didn't have anything going through your gut. Okay. If you've ever done a liquid fast, which I've done for 5 days, I pass meconium after 5 days. Okay. So meconium is just important to think about things and why they happen, right? So meconium, yes, and you expect the babies to pass when? Meconium to be passed when? By 48 hours, all right? And then you're thinking about concerns about problems with the gut structure, all right? So let's say this baby's passed meconium. What's the important question about poos then here? Rosie, do you know? really important question about poos, which might very confidently let the baby go home. Time-wise. So changing stool. Yeah, so it's changing stool. So it might not be yet yellowy, but it's changed from the sticky black stuff. So if the sticky black stuff is still here, that baby's coming in. Alright? But if you've got changing stool, that's kind of reassuring. The other thing is, how can we ask mum about milk coming in? So we're going to, because that's the other thing we want to know, is the milk in? How are you going to know that? Are there any nice questions? And then I'm going to move on.
What, as in, is the milk in the baby?
No, as in, sorry, colostrum going to milk, and colloquially we say milk's come in.
So you could ask about volume, I guess, because that's
Can
the
you?
difference.
How can you do that? You're right though, you're hitting it, you did that, you're right. The breast normally enlarge, okay? So at the point where milk comes in, now I have discussions about this with the midwives, and they say that you shouldn't have massive engorgement because that means you're failing to latch and the baby's not removing milk, but there is a degree of that. There's no question about it. Mums who breastfeed will talk about that, so that's worth asking about. You know, did you find that? The other thing, the good question is letdown. Anyone know about letdown reflex? Okay, so when the baby feeds, there's oxytocin, prolactin and then oxytocin. This rush of blood to the body, muscular contraction, feels achy, painful. Some mums really don't like it, okay? So it's some of the reason why mums don't breastfeed. They're not discussed about letdown reflex. But not all mums will get a letdown, right? But if they've got it, that's a good sign and suggests milk's in. So it's worth a question, all right? So I hope you've got a few things that you will look up. Is that all right? I'm going to leave that section now and go on to breastfeeding, okay? Anybody got any quick questions? We've got about 13 minutes to go through quite a lot of stuff. We may not be able to, Carmel. Does that all make sense? So, I mean, what I hope from these sessions is that you go away with 3 or 4 things you look up. I mean, you don't have to. I'm not your mum. But I would suggest that you do and do it sooner. It'll consolidate stuff you've learned, okay? Good. Sorry. Oops. Right. Going to think about breastfeeding, if this works. So Keith Hansen is a anchor, right? He's a banker who was involved in some discussions around the breastfeeding problems that we've got in the country, but also in the world, okay, about how little is being done at the moment. And I'm just leaving you, I don't normally put lots on the, but I just wanted you to read that because, I mean, I think that's an astonishing and correct statement. Anyone got any thoughts? Or is it very obvious? Okay, the whole implications for health and global health and global economics is massive. The fact that everyone's moving away from breastfeeding, okay, and I think it's not discussed enough at that level. And it is difficult to not become a militant breastfeeder, you know, militant breastfeeding action person. But there are some straightforward things that you can just explain to parents and mums and dads. And I think the key thing is that breastfeeding is quite difficult, okay, and I think that's something that often doesn't get talked about. We'll talk about things in a minute. Benefits breastfeeding to baby. You should have a list of 5 things. If a mum asks you, you should know this. Okay? No excuse not to, in my opinion.
Antibodies. Right,
Okay, so what are you going to say? So that doesn't mean much to parents. Remember, you're dealing with a whole load of parents with different educational backgrounds. So what are you going to actually say to them?
Help protect them against diseases.
Which ones? You can say protect. Which specific ones do we know about? Proven, research study-based stuff.
It's asthma one.
Yeah, asthma, so that's allergy type things. Good. Or atopy, I should say. Yeah? Anything else? I'm going to move you on quickly, guys.
Obesity.
Good. Okay, so it reduces obesity by apparently 13%. Okay? And if you're breastfed to at least, ideally, 6 months or beyond. And the amount of money spent in the UK every year on obesity-related illnesses, does anyone know? They think? 5 billion.
5 billion.
Yeah. All right. So I know it's unbelievable. Okay. So just to say, breastfeed. We'll come on to the benefits in a minute. But just to say, in terms of the UK, we are awful. Okay, at the level of breastfeeding. 81% at birth. Only 1% exclusively at 6 months. So that's what the UNICEF and WHO are trying to gear to, because they know that a lot of mums go back to work, so they're trying to gear up to exclusive breastfeeding till 6 months, till weaning. And then here, and this is the UK figure, sorry, it's not very clear on there. But look, the States are ahead of us. Okay. We are pretty good in Brighton though. This is the figures from 2016. We are very good. Brighton's 57% exclusive breastfeeding at 8 weeks. That's still quite a low number. And we'll talk about why. Why do you think, I've got a slide for that, but why do you think breastfeeding doesn't happen? Proven or not proven? What do you think?
So social factors.
Right, which ones?
So being out and about and
Yeah.
feeling that it's not, you can't do it.
So this feeling of getting your boob out in front of everyone. Yeah, so it's the shame thing. Okay, it's a massive thing in the UK, massive. Not so much in other cultures, and I think in the US actually it's better. Yeah. So there's a whole thing about making, breastfeeding in cafes and all that stuff. You know all about that, yeah?
Formula advertising. And
Good. That's a huge thing, a massive thing. I've got a good slide on that in a minute. Yeah.
Is there an element of concern about you don't know how much the baby's getting?
Yeah. So concern about that and the health of the baby. There's no guarantee. Okay. It's that certainty. We're in an age of certainty, aren't we? We want certainty. Breastfeeding is not certain. Okay, you have to wait. You have to wait till they get weighed next week. All right. So the certainty is a big issue, which is a cultural thing, isn't it? Yeah. Anything else?
You already mentioned it's uncomfortable.
Uncomfortable, painful, hard, nipples cracked, sleep deprivation, apparently 24% of mums cite that they won't be able to exercise. I find that because exercise does reduce breast milk volume. It does. Okay, so you have to be careful about that. Limiting their lifestyle is apparently again a survey that suggests 54% of mums want that, are worried about that. All right. So I think there's quite a few things in there. It's a cultural thing, and I don't know how much we can adjust ourselves. But thinking about the baby affects, you guys need to know this. I'm disappointed actually. I want you guys to be better at this, okay? Because I think that you need to know this, right? Mums are going to ask you. Mums and dads are going to ask you. And you're powerful, people to talk about things. You don't need to be militant. You can just say the facts. So have some facts at your hand, okay? Increased IQ is only small, 3 points. I don't know if that really makes a difference between being a Nobel Prize winner and a shopkeeper. I'm just saying it's a small, but some people have looked at that. Sorry, I didn't complete this properly. What do I mean by 15 out of 19 in Western Europe? Does anyone know what that means? Some of you might. So out of the 19 countries that are classified as Western Europe, we are 15th at the bottom of the infant mortality rate, okay? We have the 15th worst, if you like. So there's a massive initiative to, again, induce breastfeeding to reduce that. So we're talking about a lot of public health measures, okay? So there's lots of things with that. So you should know this, all right? And then you talked about infections, so there's some there for you to remember. Because that's what parents want to know, don't they? They want to know, what do you mean? What can we prevent? So mummy advantages, any of them that you know of, guys? Advantages for mum? Yeah, good.
Bonding.
Yeah, okay, so that's not slight disadvantages, yeah. How much calories do you need extra for breastfeeding a day? 500, good, yeah. So it's not that much. What's 500? It's a sandwich and a pack of crisps. It's not much. A lot of mums gain a lot of weight because they think they lose, during breastfeeding actually because they misunderstand what they mean by that, okay? But you're right though, there is documented evidence that there are low obesity rates, not during the feeding time, but afterwards, yeah? It's a long-term thing, yeah? Did you all know about this? I think this is crucial, and I've actually not put breast cancer there. Sorry, I should have breast as well up there. That is massive. What's the rates of breast cancer at the moment in the country, UK? So there's 1, 2, 3, 4, 5, 6, 7 girls here. How many of us are going to get breast cancer? 1 in 8. So one of us will get breast cancer in this room. Now, if you think of it like that, it makes it real, right? So this will reduce breast cancer. And I think there was some impressive savings discussed. If you're going to talk about it from a savings point of view, I'm not really that interested in that, but that's relevant from a health economics thing. Good. And so there's this issue about easy access, which I think gets forgotten about, okay? Don't have to worry about sterilising, all of that sort of stuff. Is that all right? And again, that's important for you to be able to talk to. Why are rates so low? We've talked about this. So everybody thinks it's going to be like this, but it's often like this. It's hard work, okay? And I think people talk about breastfeeding being easy, but actually it's hard work. I breastfed 4 of mine, so it's easy for me to say that, but I'm just genuinely, it's harder work than people, and I think that just needs to be an honest truth sort of discussion, okay? And so the UNICEF UK talk about we need access to information about breastfeeding, predictable, sorry I spelled it wrong, face-to-face, easy access, and predictable, meaning you can get something if you ask for it, and that's a real challenge at the moment, okay, because we don't have enough people around. Even to get breastfeeding support on the ward, when you guys want that, you'll see how difficult that is, and that's in this institute when we've got a grade, a tertiary level neonatal unit over there. Rosie probably has worked there, so she probably knows yourself. It's not that easy, is it, even for mums on the ward? So the midwives do it, but if we want access from outside of the midwife and labour ward, it's very difficult. It's not impossible, it's just challenging. Good, okay. That was a bit of a whistle-stop thing, and I want to talk about at least two things. I'm gonna talk about colic for a minute. Oh, I've just given you the answer. Okay, 14 weeks old, cries every night. This is your case. You're going to see this in GP land, in CED, and we admit some to the ward, okay? So it's in every aspect. You shouldn't see them in HDU. I've just told you the answer. Okay, so we're thinking about colic. What is colic?
Bowel spasm?
Does anyone know what it is?
Does
anybody know?
Does anybody?
Does anyone in the world know what colic is? What's it presumed to be?
Presumed to be within a normal thing.
Yeah, I think that's where we're coming to. It's within the normal neurodevelopmental profile. Okay, and there's a range of babies that probably cry more than other babies. Okay, that's probably where we're getting to, because we know it stops by 4 months. All right, so there's a lot of things that stop at 4 months neurologically that we know of. Changes in reflexes, yeah? Loss of your primitive reflexes, a whole load go by 4 months. So maybe colic is another thing that's associated with that kind of profile, yeah? Change, is that all right? So that's not easy to say to a parent though, is it? Okay, it's much easier to say there's something wrong with your tummy, isn't there? Okay, and that is the assumption about colic, isn't it? That it's gut related. And people cite that, often babies pass wind and they feel better. So there's some associations with gut issues, yeah? But I don't think anyone can say that for sure. And if you look on the literature, it's classified as a functional disorder, okay? So Rome 3 criteria, this is the guy that put this out here. I think the key thing is, so this is the rule of threes, they call it. Remember I said 3s and 10s in medicine, okay? So he's just done that to make it easier to remember, hasn't he? So what I'm saying is, do you need this exact criteria to call it colic? No. So it's just being mindful that it's probably a longer term thing. It's not going to be just a one-off episode. That's not going to be colic. That might be interception. Yeah? So something like that is just more chronic. It's usually long, but it doesn't have to be more than 3 hours. Okay? And I think the key message for me is this. It's sudden onset, sudden offset. And really nobody normally knows what's triggered it on or triggered it off. Okay? That's quite useful to think about. So there is some... are you all right for a few minutes?
Yeah.
It's only
We're
because...
talking about colic.
Yeah, I'm talking about... there's this recent discussion around smokers. So smoking parents have been associated with babies that have increased motilin in their bloodstream, and the parents as well who smoke. And this apparently is something that people think about, because there is a documented association of increased babies with increased colic with mums and dads who smoke. Okay, but I don't think anyone knows that. But for that reason, some of these other drugs have come up, which are all gut related. But I agree with your young lady at the back there that neurodevelopmental causes are where we're going with this. And I think it is useful to tell parents that, because what does it give them? Reassurance and... yeah, an end point. If you say that it's going to finish by 3 to 4 months, that makes a massive difference, because at that time, that parent, that's all that's happening, and they can't see beyond that. So that can give you an idea of things improving. Is that okay? So again, I wouldn't worry about looking that up so much, but I do want you to go back and think about breastfeeding, some of the other things that we've done, and get those at your fingertips, okay? Last case, is that right? 3-month-old, if anyone gets this, I'll be well impressed. I knew Ollie would wake up at that one. Case 2, so a 3-month-old baby's crying. This is a case that I had in my clinic, okay? Crying most days, usually while straining, gets really red when he strains. Puce, he goes really puce. Mum showed me a video. And they've had a rectal biopsy for, what's rectal biopsy done for? Good, okay. They've already had a rectal biopsy by the surgeons, and he's been treated for lactulose for What do you treat? Why is lactulose given? Constipation. Okay. So he said that and come to me. Right. What are the important questions in the history?
You vomiting?
Good. No vomiting. I'll be really quick, guys, but this is an important thing. No vomiting.
This is anus at normal, there's no
Yeah, normal
fissures.
anus. What's the question about early history, Hirschsprung's related? What you're going to all ask?
Okay, about meconium.
Good. So meconium, was it passed within 48 hours? Yes. Oh, you've got no other questions?
Is he growing okay?
Yes, he's growing. He's growing okay. Yes, growing well. Head, circumference, and body, and length.
Physical examination, okay, no murmurs.
No murmurs. Examination, tie normals, loving it, gurgling at me.
He's faking it.
Okay, so we've got faking.
How's he feeding?
He's feeding by breast. So actually, it's a good question, but actually there's documented things with both breast and bottle for this condition. It's a functional disorder. So functional we think made up, but actually functional also means normality causing a sort of extremes of normality. So functional is used in lots of different ways, isn't it, in medicine? Functional for made up, but functional for normal function coming out the extremes, okay? So this is where we are at. This goes away at 6 months. Anybody know the answer? Registrars. You're going to see this. I've seen lots of this. And actually the main issue is that a lot of clinicians don't know about it, okay? Anybody? I'm not going to test the boys.
How do you spell it?
Oh, okay. Yeah, I've got it. Right, so, I mean, the study shows that there are research people that have looked at this, okay? Only 70% probably, and I think actually it's a lot less than that, of clinicians know about this, okay? Under 6 months, did anyone get that in their minds? Anyone know it? Don't worry if you don't, because I think one of my things is to get this, because I've seen like 2 kids, maybe 3, have had rectal biopsies for this. I think I've talked to you about it before. So this is again a part of a neurodevelopmental thing. What do you need to poo? What things have to happen to poo? When you go for poo, what do you